Welcome to Cardiovascular Disease. Today we will talk about coronary artery disease, or CAD, C.A.D, atherosclerosis, and thrombosis. We'll take a look at normal coronary arteries and veins in the human body, and we will go over the physiology of atherosclerosis and the microanatomy of thrombosis. Arteries and veins are called coronary arteries and veins. Each coronary artery and vein of the heart has a special scientific name depending on its location, origin, branches, and tissue that it perfuses. The left and right coronary arteries are located along the coronary sulcus of the heart and supply the heart walls. These coronary arteries are branches of the ascending aorta just superior to the aortic semilunar valve. The right coronary artery branches into the right marginal artery, which supplies the right border of the heart. The posterior interventricular artery supplies the posterior surface of both the left and right ventricles. The left coronary artery typically branches into the anterior interventricular artery, also known as the left anterior descending artery, which supplies the anterior surface of both ventricles and most of the interventricular septum. The circumflex artery supplies the left atrium and ventricle. This arterial pattern can vary greatly among individuals. For example, some people may have a posterior interventricular artery that is a branch of the left coronary artery. Knowledge of this variation is essential when treating individuals for coronary artery disease. The right and left coronary arteries share some tiny connections called anastomoses. However, if one of these coronary arteries becomes blocked, then the blood flow will not be sufficient to supply this region of the heart, and so the heart muscle tissue dies. The coronary veins return the blood to the heart chambers. The great cardiac vein runs alongside the anterior interventricular artery. The middle cardiac vein runs alongside the posterior interventricular artery. The small cardiac veins travel close to the marginal artery. These cardiac veins drain into the coronary sinus, which is a large vein that lies in the posterior aspect of the coronary sulcus. The coronary sinus drains into the right atrium of the heart. Arteries that have atherosclerosis or coronary artery disease, known as C.A.D. or C.A.D, may not be able to deliver a sufficient amount of blood to the heart. They may experience coronary spasms, which cause temporary narrowing of the artery, leading to angina. If blood flow is completely cut off, then the myocardial tissue will die. This is called a myocardial infarction. This image was taken from the Internet Pathology Laboratory for Medical Education, hosted by the University of Utah Eccles Health Sciences Library, and it can be viewed at the link listed below. This image is of a normal coronary artery cross-section. There is no atherosclerosis present. A normal coronary artery seen in this cross-section at low power has 3 layers: the intima, the media, and the adventitia. The 3 major coronary branches, which would be the left anterior descending coronary artery, the left circumflex coronary artery, and the right coronary artery, which supply blood to the heart. The intima is a thin layer that is very indistinct. The media is smooth muscle that forms the bulk of the artery, and the adventitia, or the externa part of the artery, is on the outside, and it merges with the surrounding connective tissue, epicardial fat, and connective tissue. This image was taken from the Internet Pathology Laboratory for Medical Education, hosted by the University of Utah Eccles Health Sciences Library. This image can be viewed at the link listed below. This image is of a normal coronary artery, and this image says, distally, major branches of the coronary artery bifurcate to small branches. This here is an image of a muscular artery that is 3 layers. It has the thin intima layer that is facing the lumen of the artery, and then below that is the media layer, which is composed of smooth muscle tissue, and there is a layer called the external elastic lamina, which is elastic connective tissue, and then the outside layer, which is outside of the media layer, is called the externa, or the adventitia layer, and this merges with the surrounding connective tissue. This image was taken from the Internet Pathology Laboratory for Medical Education, hosted by the University of Utah Eccles Health Sciences Library. This image can be viewed at the link listed below. Here, this image is showing a cross-section of a normal artery and a normal vein. That means it is not a diseased artery or vein where atherosclerosis is present. You can see that the artery has very thick layers and a very thick media layer, which is composed of the smooth muscle tissue layer, and the vein appears collapsed and has a very thin smooth muscle layer, and therefore appears collapsed in the image. And again, oftentimes arteries and veins are grouped together along with a nerve in a neurovascular bundle. This image was taken from the Internet Pathology Laboratory for Medical Education, hosted by the University of Utah Eccles Health Sciences Library. This image can be viewed at the link listed below. This image is of a normal arteriole and venule where no atherosclerosis is present. So this is a non-diseased artery or arteriole and venule. And they are oftentimes grouped together. As you can see, the arteriole is much thicker and has thicker layers of smooth muscle, and the venule is more collapsed in appearance and has a larger lumen. And oftentimes there's a nerve adjacent to the arteriole and the venule in a neurovascular bundle. This image can be viewed at the link listed below at the Internet Pathology Laboratory for Medical Education, hosted by the University of Utah Eccles Health Sciences Library. This image is of a coronary artery that is diseased and has atherosclerosis, and a calcium deposit can be seen. See how small the remaining lumen of the vessel shown here has become? There is also a deposit of calcium, which is the blue area at the lower right. There is a coronary artery, and the patient here is at risk for an acute myocardial infarction. Sometimes called hardening of the arteries, atherosclerosis is a progressive process in which the lumen of a muscular artery becomes narrowed through the deposition of lipid material. Increased levels of lipids, particularly cholesterol, contribute to the development of atherosclerosis. Narrowing of arteries reduces blood flow to tissues distal to the artery. This may cause the cells to become smaller or atrophy if they have time to adapt, or the cells may die. This image was taken from the article, The Role of Lipids and Lipoproteins in Atherosclerosis, and the caption was taken from the article, Nutraceutical Therapies for Atherosclerosis, in the journal Nature Reviews Cardiology. This image is depicting the physiology of the initiation or formation of the fatty streak of atherosclerosis development in an artery. So, formation of an atherosclerotic plaque is caused by the expression of the pro-inflammatory genes including ICAM1 and MCP1, and is triggered by the buildup of modified LDL cholesterol in the neighboring endothelial cells during the development of the initial lesion. Circulating monocytes, which are white blood cells, are then recruited to the modified LDL accumulation and migrates into the intima layer of the artery and differentiate into macrophages, which is a phagocytic white blood cell. Once in the walls of the artery, the macrophages are able to take up the modified LDL cholesterol and become lipid-laden foam cells, which can accumulate and form a fatty streak in the walls of the artery. During complex lesion formation, foam cell lysis by apoptosis and necrosis leads to the formation of a necrotic core, and together with defective atherosclerosis leads to the amplification of the inflammatory response. Smooth muscle cells begin to migrate from the media to the intima, and extracellular matrix produced by them forms fibrous cap and stabilizes the plaque. Smooth muscle cells also transform to foam cells. During later stages of the complex lesion, the plaque can become unstable owing to the inflammatory response, resulting in an inhibition of extracellular matrix formation, particularly collagen production by the smooth muscle cells. The remaining extracellular matrix can then start to be degraded by proteases released by macrophages, resulting in an unstable lesion that can rupture and lead to thrombosis. These events can cause a myocardial infarction or stroke, depending on the location of plaque formation. Extracellular matrix ICAM1, intracellular adhesion molecule 1, LDL, low-density lipoprotein, and MCP1, macrophage chemoattractant protein 1, SMC, smooth muscle. This image was taken from the Internet Pathology Laboratory for Medical Education hosted by the University of Utah Eccles Health Sciences Library. This image can be viewed at the link listed below. This image is of a coronary artery with atherosclerosis along with the development of a thrombosis. This section of coronary artery demonstrates remote thrombosis with recanalization to leave only two small narrow channels. This image was taken from the Internet Pathology Laboratory for Medical Education hosted by the University of Utah Eccles Health Sciences Library. This image can be viewed at the link listed below. This image is of an atherosclerotic artery, coronary artery, and it has a thrombosis, a recent thrombosis that can be seen within the lumen of the coronary artery. As you can see, there is a pink to red recent thrombosis in this narrowed coronary artery. The open needle-like spaces in the atheromatous plaque are cholesterol clefts. This image was taken from the article Pathophysiology of Coronary Artery Disease. This article was published in the journal Circulation, originally published June 27, 2005, and written by Peter Libby and Pierre Thoreau. Circulation is a journal that is part of the American Heart Association. In this figure, you see the rupture of a fibrous cap, which is part of the microanatomy of coronary arterial thrombosis and acute occlusion. The rupture of fibrous cap causes some of 2/3 to 3/4 of fatal coronary thrombosis. And in B on the right, you see a superficial erosion. A superficial erosion occurs in 1/5 to 1/4 of all cases of fatal coronary thrombosis. Certain populations, such as diabetic individuals and women, appear more susceptible. Figure 3. Microanatomy of coronary arterial thrombosis and acute occlusion. Part C shows the erosion of calcium nodule. The erosion of a calcium nodule may also cause plaque disruption and lead to thrombosis. This can be seen in Part C on the left side. On the right side, we see the picture D, and in addition to the microanatomy of coronary arterial thrombosis and acute occlusion, you see that friable microvessels in the base of the atherosclerotic plaque may rupture and cause intraplaque hemorrhage, leading to a thrombosis. E. Consequent local generation of thrombin may stimulate smooth muscle cell proliferation, migration, and collagen synthesis, promoting fibrous and plaque expansion on subacute basis. Severe intraplaque hemorrhage can cause sudden lesion expansion by mass effect and acutely as well. The remaining slides are of the resources and references used to create this video. Thank you for watching.